Good morning, everyone. Welcome to the Department of Neurosurgery Grand Rounds. It's my pleasure to introduce Dr. Heather Abernethy from the Department of Anesthesia. She's going to give us a talk today about really the kind of the hybrid between communication, psychology, and care of both patients and practitioners. So that despite the word trauma in here, it does not involve necessarily physical trauma, but more emotional and social trauma. So I've heard very good things about this talk, so I'm looking very forward to it. Thank you for coming, Heather. Thank you.
Thank you for inviting me. Hi, I'm Heather. I'm an anesthesiologist, and as an anesthesiologist, I have a lot of training, as do you, in how to keep people safe. But throughout my education, no one ever talked to me about how to help someone feel safe. So I am thrilled that you invited me here today to talk about trauma-informed care. I have no disclosures to share with you. I was assigned to take care of a patient who'd be coming in for her third attempt at a lap chole. The first surgery, she arrived, she met her anesthesiologist, and immediately after left the hospital. The second time, she made it into the operating room. However, she became combative when the mask was put over her face, and the anesthesiologist canceled the surgery because she was dangerously out of control. You see, the problem was she was difficult, demanding, manipulative. At least that's how she was presented to me by multiple people. But the interesting thing is that when I talked to her, her previous behavior made sense. You see, early in her life, people with power over her had hurt her. She told me, I was raised in an abusive household. I had a chronic alcoholic father. My mom wasn't around. Our home life was chaotic and very unstable. And she once again found herself in a position where others had power over her, and she would be losing all control. When we got to the waiting area the morning of surgery, she said I was calm. But when I started walking back to the room, my anxiety went from non-existent to exceptionally high. Within minutes, I was shaking, sweating, crying uncontrollably. I had zero control over my body, and that was terrifying. She wasn't intentionally being difficult or demanding. She was traumatized. After she described her first two experiences to me, I told her that makes so much sense. There's nothing wrong with you. She started to cry and she said, it does. Everyone thinks I'm crazy, but I'm not trying to be difficult. My body takes over. Despite childhood trauma being a leading determinant of our health and well-being, healthcare providers are just recently being educated on trauma-informed care. Trauma-informed care is grounded in a set of 4 key concepts, the 4 R's. First of all, realizing the widespread impact of trauma and how reactions to past trauma may impact a person's current behavior. Recognizing the signs and symptoms of trauma. So this patient had a flight response the first time, a fight response the second time. Resisting re-traumatizing, preventing a tolerable stress from becoming a toxic stress. Healthcare settings, they're places of healing, but often our interactions with our patients are re-traumatizing. And responding by integrating this knowledge into policies, procedures, and practices. And I think if the staff had had training on trauma-informed care, it wouldn't have taken 3 times to have a successful surgery, and she wouldn't have been left with an even greater distrust of the medical community. But this is easier said than done, because becoming trauma-informed requires a paradigm shift from what's wrong with you to what happened to you. How have you tried to deal with it? And from here's what I can do for you to how can we work together to meet your goals? Now, we know paradigm shifts take time. It's only 10 years ago that SAMHSA, which is the Substance Abuse and Mental Health Services Administration, published the first guidelines on trauma-informed care. 2018, federal law mandated trauma-informed care principles across all federal agencies, including NIH, Medicare, Medicaid. In the years since, numerous academies have called for education on trauma-informed care, and there are now, since 2022, published validated trauma-informed care core competencies for undergraduate medical education. Now, before we go further into what we're talking about with trauma, let's give a definition. This is how SAMHSA describes trauma. Individual trauma results from an event, a series of events, set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, that has lasting adverse effects on the individual's functioning and mental, social, psychological, emotional, or spiritual well-being. Now, there is a lot in there, so I find it easier to talk about the 3 E's of trauma. There's the event. This is an actual event, or it can even be a perceived event of physical or psychological harm. It can be severe neglect. It can happen one time, or it can be recurring. And then there's the experience of the event, because trauma is not experienced the same by everyone. You may have 2 people in the same motor vehicle crash. One person may walk away upset, disturbed, but the other person walks away with PTSD. Trauma is not what happens to you, it's what happens inside you as a result of what happened to you. I think an event is traumatic if you're more limited in your views and in your abilities to respond than you were beforehand. Trauma constricts you. Trauma is experiencing fear in the face of helplessness. Traumatic events, they set up a power differential where an individual, an event, a force in nature has power over another. And then the effect, because long-lasting adverse effects are a critical component of trauma. They can occur immediately, or they may have a delayed onset. Trauma is an event that overwhelms the central nervous system, altering the way we process and recall memories. So some people say trauma is too much too fast. There's so much coming at you that you can't take it all in and put the pieces together. You guys deal or take care of patients in the ICU. You can understand how that happens in the ICU. There's a lot going on, a lot coming at people. We know that the ICU-related PTSD incidents can be up to 10%. And it's easy to understand this in the ICU, but this doesn't just apply to your patients who are in the ICU. It was not that long ago with the DSM-3, which is when PTSD was described as occurring from being exposed to an extraordinary event that is beyond the range of normal human experience. Since then, we've found out that they were wrong, and research has revealed the myth of normal. An important part of understanding trauma-informed care is understanding the science of ACEs. I'm curious how many of you guys know about the ACEs study. Okay, a few. I'll go over it. I think the background is really interesting. ACEs stands for Adverse Childhood Experiences. It's a groundbreaking study that was done in the late 1990s, over 17,000 middle-class Americans. They were followed for 15 years by the CDC and Kaiser. And the ACEs study revealed a really powerful relationship between what happens to us as children, our physical, our emotional experiences, and our physical and emotional health as adults. It showed that our traumatic childhood experiences are converted into organic disease in adulthood. The ACEs study started with Dr. Folletti. He was the chief of the Department of Preventive Medicine at Kaiser. He had a very successful obesity clinic for people who were 100+ pounds overweight. And despite huge amounts of weight loss, 50% of the people dropped out of the study. And to figure out why, he interviewed about 300 of them. And he asked them, how much did you weigh when you were born? How much did you weigh when you started high school? And then he misspoke. And instead of asking, how old were you when you were first sexually active? He asked, how much did you weigh when you were first sexually active? And the woman across from him said 40 pounds. And he was sure that he misunderstood, but he misspoke again. This time she gave the same answer, burst into tears, and said, I was 4 years old. It was with my father. As interviews continued, he discovered that 55% of people in the obesity clinic had experienced childhood sexual abuse. And he discovered many, many more forms of abuse. It was at this time that Dr. Anda, an epidemiologist from the CDC, joined, and they helped design the ACEs study to see if these factors that he found in the obesity clinic also existed in the general population. In the ACEs study, they asked adults about their experience with these 10 different categories: abuse, physical, emotional, sexual, neglect, physical, emotional, and household dysfunction. Did you have a parent with a mental illness? Was someone incarcerated? Did you see your mother be treated violently? Was there someone with substance misuse? Or did one of your parents, did they get a divorce? What I like to point out here is this neglect category, because I think that people think trauma is something bad that happens to you, but trauma is not just the bad. Trauma is also not enough good. And I think what this reflects is, were you seen? Were you heard? Did you have your feelings validated? And did you matter to someone? So trauma was considered out of the ordinary, but the key findings of the ACEs study show that ACEs are very common. This study was among a population largely Caucasian, middle class, middle age, highly educated. 75% had a college education. They were employed with good health care. About 2/3 of the population experienced one or more ACEs, and of those, 90% experienced two, because ACEs don't usually happen in isolation. 1 in 8 adults had experienced 4 or more ACEs. This means that you see patients every day with high ACE scores. This means that in this room, many of us have high ACE scores. ACEs are also strong predictors of later health risk and disease, and there's a dose-response relationship. There's a powerful persistent correlation between the more ACEs experienced and the greater your chance of a poor outcome. Things start getting serious with an ACE score of around 4. The relative risk of heart disease, cancer, tobacco abuse more than doubles. Things like substance misuse, 6 times, depression, 7 times, suicidal attempt, 12 times. ACEs dramatically increase the risk of 7 out of 10 of the leading causes of death. And without intervention, the life expectancy for someone with an ACEs score of 6 or more is 20 years shorter than someone with 0 ACEs. What is important to remember is that this is a population study. This is not predictive of any individual. Now, since the ACEs study, the definition of adversity has expanded to include community causes, environmental causes, things such as community violence, systemic racism, individual racism, poverty, bullying, natural disasters, pandemics. And our patients have been impacted by all forms of trauma. And these patients are likely the ones who come to you with the most complex health issues. Now, not all stress is bad. I'm not saying we shouldn't have any stress or adversity. Some stress is healthy because it helps us respond to temporary challenges, such as an emergency surgery. Our stress response is tolerable when it activates, but then it quickly returns to baseline. Positive stress, it's short-lived. Tolerable stress, it's more serious, but it's usually buffered by supportive relationships. And then toxic stress. This is pervasive, it's unrelenting, it offers no respite, it's this person's normal. And severe or frequent exposure to certain types of stress without a support system can have a toxic effect on our body. The reason for this has to do with the hypothalamic pituitary adrenal axis. Jack Shonkoff, he's a pediatrician, he's also the director of Harvard Center on the Developing Child. And he says it this way. He says, all of our biological systems are highly interconnected. They're designed to adapt to our environment. When we have a stress response, our brain senses this, and it sends signals to the cardiovascular system to increase heart rate, blood pressure, which is picked up by the metabolic system, to increase blood glucose, to provide energy to mobilize. The immune system is activated, so we have a release of pro-inflammatory chemicals. The neuroendocrine system is activated, increases levels of adrenaline and cortisol, and all of these provide feedback to the brain. And our stress response is designed to deal with acute stress. But with chronic stress, it stays activated even when there is no apparent threat. And this has a wear and tear effect on our bodies. Dr. Nadine Burke-Harris, she's the former Surgeon General of California, and she says, the stress response works really well to help us accelerate when we're being chased by a bear. But what happens when the bear comes home? night after night. Well, the good news, the really hopeful news, is that ACEs are not our destiny. This is a study that was done on a Wisconsin population, and it looked at childhood positive experiences. Similar to the ACEs study, but it asked questions looking at, did you feel safe in your home? Did you feel protected? Could you talk to someone in your family? Did your family support you? Did your friends support you? Did you feel like you belonged to your community? Did you belong in school? And it looked at the effects of positive childhood experiences on groups with different ACE scores. And what it showed is that people who've experienced significant adversity or who have many ACEs, they are not irreparably damaged. Positive experiences help children be resilient in the face of adversity. What it showed is that those, the yellow line, those with 4 or more ACEs were the most profoundly affected by positive experiences. I think, again, this is because we're wired for safety and connection. I think what this shows, again, is where you've seen, where you heard, did you matter? This is a basic core need that we all have. It's also a need that our patients have. And one of the ways that we can show our patients these things is by asking open-ended questions, such as, have you had any life experience that makes seeing a doctor difficult for you? How has this impacted you? What could we do to make this easier for you? These questions allow your patients to determine what they want to share, and it avoids prompting them to recall any details of a specific event. Because trauma-informed care does not require you to know about the trauma. You actually want to minimize the need to retell the story. How many people need to ask someone, how did this happen? I took care of a patient who was having a shoulder arthroscopy. And between when she was checked in and when she went into the OR, 5 people asked her how this happened. And how it happened is her husband pushed her down the stairs. So not everyone wants to talk about the event. There's numerous ways that we re-traumatize our patients, either in the system of medicine or individually. You can read through these, but again, when you look at the relationship, not being seen, not being heard, this goes a long way with our patients. The patient I took care of, when she recounted her previous experiences, she gave a few examples where I recognized some instances of re-traumatization. She said the anesthesiologist would bounce back and forth between helping and instilling more fear. 1 minute I felt safe, the next I was terrified. Non-collaborative, the charge nurse said in front of me, just get the Versed in her. Treating patients like they don't know what's going on is not only insulting, but it makes us feel like we don't matter. Using coercive language. The anesthesiologist told me if I didn't have the surgery, I could end up intubated in the ICU. All of those stories introduced new fears that I didn't have before. So we want to resist re-traumatizing our patients. And what do we want to do? Well, there are 6 guiding principles for a trauma-informed approach. Safety. So when I talked to this patient, I made sure the environment felt safe. I minimized the distraction. I sat down so we were eye level. I made sure I didn't block the door. I spoke slowly. I moved slowly. Trust and transparency. Knowing what to expect builds trust. So I let her know it would be happening every step of the way. Peer support. Recognizing that other people feel the same way you do. So I let her know you are not the only patient who feels this way. Collaboration and mutuality. Making decisions with our patients, partnering with patients, because healing happens in relationships. So when I needed to start an IV, I asked her, what hand do you want me to take a look at? Cultural, historical, and gender issues, moving past stereotypes and biases. So with this patient is moving past stigmatizing language, where she met the stereotype of the difficult patient. And when I approached her, I let her tell me her story. And after our conversation, she went into the operating room feeling safe and came out having had a successful surgery. So if you know the 4 R's, the 6 guiding principles, are you a trauma-informed physician? Well, what makes a physician trauma-informed? I like the definition that's on Columbia Medical School's website. This is how they defined a trauma-informed physician. They say there's no accepted definition of a trauma-informed physician, nor a blueprint for how to become one. We believe that a trauma-informed physician is one who embodies more than knowledge about trauma, its health effects, and the principles of trauma-informed care. A trauma-informed physician is one who also possesses a deep sense of self and other awareness, has compassion for how life experiences may shape a person, and can create a feeling of safety in themselves, their patients, and their patients' families. The thing is, healthcare providers, we have ACEs scores similar to those of the general population. So we may be triggered by our own ACEs, which interfere with providing good care for our patients. So I think trauma-informed care, it's not just about finding the right thing to say. It's nonverbal. It requires you to do your own work. So you can be comfortable with discomfort and you can stay regulated when someone's dysregulated. This is where I find this chart of trauma response really helpful. It's used at the VA, at GHC, I know uses it. It's used actually around the world for how to help and approach people who are suffering from PTSD or other traumas. And what it says is that our brains are prediction machines. So we're always predicting what's going to happen, based on what has happened. And we take in information from outside our environment, from inside our interoception, how we feel. Do we have butterflies? Is our heart racing? And then between us and other people, because there's a resonance on the nervous system level. And this green state is a state of presence. It's when we're present with our body, we're embodied, we're connected to other people. I call it the state of the C's. It's where we're calm, curious, compassionate, centered, courageous, connected. But we may sense threat. If we sense threat, we may move into the sympathetic response. We all know this. We live here a lot as physicians. It's the I can state, right? The hyperarousal state. And you may have associated feelings, emotions of anxiety, irritation, anger, fear, panic, rage. But if you continue to sense threat, you may move into another state, which is where things are just too much. It's the overwhelmed, shut down, collapsed state. This is the I can't state, right? And you may feel trapped, confused, hopeless, helpless. This is where you experience shame, suicidal ideation, or you may dissociate from your body. You just kind of check out. You're no longer in touch. And I find this helpful because I think we can start by maybe recognizing some of the signs or symptoms in our patients of what state they may be in. Just a quick example, sorry, this is not how it looks on my screen, but this is the state of social engagement. So you are calm, you're relaxed. When you walk into a room, maybe your patient easily makes eye contact with you. They have open body language. They're speaking clearly. They're making clear decisions. They're asking clear questions. Or they may be in a sympathetic state. You walk in, they may just appear fearful, but maybe they appear calm, but you notice they're really fidgety. Their leg is bouncing up and down on the bed. Maybe they're edgy, they're angry, they're on the defensive. Do you find yourself on the defensive? Or if things are too much, they're overwhelmed, shut down, they may have a flat affect, appear apathetic, uninterested. They don't want to make eye contact with you. It's a little too much for them. They may make themselves small. I've walked into a room before where patients cover themselves with a blanket when I walk in. They're disconnected. Or do I find it hard to connect with them? That's a cue. So as healthcare providers, our job is to do no harm. But that's not enough. It's not enough to simply avoid causing harm. In order to downregulate our threat and survival response, we need to work to actively cue signals of felt safety for others. So when we look at our patients, we move slowly, we talk calmly, we touch their hand, we smile with their eyes. Our body language is open and inviting. Our patients sense that, and their physiology calms down. Please take responsibility for the energy you bring into this space. Jill Bolte-Taylor, have you guys heard of her? She wrote a book called My Stroke of Insight. So she's a Harvard-trained neurosurgeon and she had a massive stroke. It's interesting in this book, she describes how she knows where her stroke is as it's happening and everything. But she spent months in the ICU, intubated. When her doctors or nurses walked into the room, she could tell whether they were there to just check off boxes and meet their agenda or whether they were there to connect with her. She could sense their energy. So before we walk into a patient's room, you can ask, what state am I in? If we're in a defensive state, we are going to pass that on to our patients. But we work in a chronically stressful environment. If we have an event that increases our stress response and we don't get to come back to our baseline stress response, over time we bring our baseline closer to our dysregulated state. This difference is called our allostatic load. It's the wear and tear that accumulates on our body from chronic and traumatic stress. So when you have an emergency in the operating room, you need to mobilize. You need to have a sympathetic response, but then you need to come back to your baseline when it's all over, right? Actually, I just was reading this book last night. I just grabbed it. I have this thing with reading neurosurgery people. This is a book by James Doty. He's a neurosurgeon. And he says, tumor work is painstakingly slow and precise. Eyes looking through a microscope for hours, focused on one thing. As surgeons, we are trained to shut down our bodily responses as we operate. We don't take bathroom breaks. We don't eat. We've been trained to ignore when our backs ache and our muscles cramp. So earlier, right, I mentioned stress is positive or tolerable when it comes back to baseline. So when your tumor resection is over, you need to come back, you need to find your presence, and you need to come back to your body, which you dissociated from. And we can use micro moments of returning our nervous system back to baseline throughout our day to make a difference for our patients and ourselves. So because I'm an anesthesiologist, I use the ABCs. I'm just going to share the trick I use, or the tools that I use: awareness, breathing, and connection. So awareness, I just become curious. What state am I in? What do I sense? How do I know that I'm in that state? And then breathing, because so often we're bracing for the next event to come and we take really shallow breaths, like guppy breaths, or we hold our breath. I like the physiologic sigh. There's a lot of different breathing techniques. The reason we hear so much about breathing is that it actually works. So there's box breathing. The Navy SEALs do this. I like the physiologic sigh. What it is it's 2 inhales followed by a long, slow exhale. And the long, slow exhale, like you're breathing through a straw, it activates our parasympathetic nervous system. So it looks like this. It's a... You do a few of these and it will relax your body and your nervous system. You can YouTube this. Andrew Huberman talks about this a lot. And then connection. Connecting again with ourselves, being embodied. And how I do this, I routinely supervise 3 to 4 rooms. I'm running around all day, getting pages all day long. Before I walk into a patient's room, if I'm like running, they're waiting for me to pre-op a patient, before I go into their room, I stop. And I do this really quick, the ABCs. And what it looks like, it takes just a few seconds, is I slow down, I drop in. Okay, what do I notice? What state am I in? Usually it's a defensive state. And then I breathe out. I do a sigh, and then I look up. And the looking up is just recognizing common humanity. That, okay, I'm not the only anesthesiologist or physician or healthcare provider who feels this way right now. There's a lot of us who feel this way right now. And that brings about a curiosity, because you cannot be curious and judgmental at the same time, right? And trauma-informed care is not just for our patients. It's for us too. In medicine, we're confronted with stressful, traumatic experiences, vicarious trauma, moral injury. So recognizing the signs and symptoms, realizing that this is a common issue, responding with tools to put into practice, right? We know burnout is at record highs, emotional exhaustion, decreased satisfaction caring for others, and depersonalization. And depersonalization is defined as a hollow, numb feeling where you feel shut down. It's that part again of dissociating from your body, not feeling yourself in the present. Do the best you can until you know better. Then when you know better, do better. I think knowing about the science of trauma, the science of positive and adverse childhood experiences allows us to take what we know and it allows us to do better. I'm continuing to know better, trying to do better. With every department that I've spoken to, I have learned something from that department. When I spoke to the orthopedic surgery department, Dr. Lang shared that he's learned over the years how important the first clinic visit after somebody's been discharged from the hospital is. He said that he's found that he books extra time for that because patients want to know what happened. And what I think this is there's so much going on in the hospital, then they get discharged and it's that trauma is too much too fast. They're trying to put the story together and they can't. So taking some extra time on that first visit, explaining what happened, sharing what you remember about the experience can be very helpful. We just have a few minutes left, but you guys are really experts in this area of working with people with trauma, medical trauma, right? Trauma everywhere in the ICU and the ED. And I would love to learn from you guys what you do and what you have found to be helpful. And I think you may learn from each other also. So I want to open it up for discussion. And these are some questions I'm curious about. How do you cue felt safety to your patients, especially patients who are intubated, who are nonverbal? How do you stay regulated when everyone else around you is dysregulated? And how do you decrease your allostatic load so it returns to baseline once the situation is resolved? Would anyone want to share any of those things with me, with each other?
Start with the first one. I think the single most important thing when you say walk into a clinic room, a person who had received a note from some APP's assistant saying, your test unexpectedly shows you have a brain tumor, go see Dr. Dempsey, is they think they're going to die. They think they'll lose their hair. They think their family won't know them. They're scared to death. And the goal of that whole visit is to empower them to be in charge of their care. And I become an assistant to them or a consultant to them. This is your visit, from the knock on the door to asking permission to enter their consultation to the naming by name, even though I can't remember names, everybody they brought, everybody I brought, till they feel some sense that they can regain control of the situation, and I'm there to help them. I think that's probably the most important thing that resonates there.
Thank you for sharing that. I'm curious, Dr. Dempsey, if that's something that you have always done, or if that's something that has developed over time.
And people always ask me, like, who taught you how to do the surgery this way? And the answer is nobody, everybody. And it's constantly changing, constantly learning. Otherwise, I get very, very bored. Constantly learning. Every patient teaches you something worldwide.
Thank you. Yes.
Yeah. Spine. So everybody's.
Yes.
Yeah, I got much better over the years. That's good information. 1 years ago, doesn't so lost just giving education. Very, very skilled.
Yeah. Yeah.
I think it focus on three. So one of the things that we see as neurosurgeon, practice neurosurgery is a uniquely something special. Every two lens and it's neurosurgery. So you should be really important, especially for your first 5 or 6 years to get some highs. Get out of yourself, be mad at something. To do something just pure problem. My strategy, my songs.
Yes, play or fun or, yeah. Thank you for sharing that.
I think for number one, doing health safety. In our neuro ICU, I try and create a very ordered environment that they feel that things are very well regulated and that it's not chaotic. As a result, your airplanes and they're able to do safety patients. If your staff feel like the environment is potentially chaotic, you're going to stress patients.
Absolutely, we co-regulate, right? So we're like that, our patients will be like that. So I'm curious, how do you keep yourself calm, or the appearance of calm maybe?
It takes a lot of work.
Yeah, it's a practice.
I think that coming into an environment and like displaying a lot of aggression and sort of creating chaos will make your staff check out. So instead, sort of project home and yourself or stress on people. Actually, positive environment.
Yeah, the environment is really important. And that's great that you recognize that it trickles down.
These aren't new concepts. Like when I was coaching, techniques, diversity. Primary characteristic of a physician is to be able to maintain a steady demeanor. It's not new. It's generation.
I mean, there's a reason obsessive compulsive people end up in surgery, because after the, chaos, after the, we put our toys away. It's like our mother told us. And we're doing that so that we feel comfortably we're prepared for the next emergency. And that sort of attitude where after the crisis, we debrief what we do right, what we do wrong. We learn from it. We put our toys away so we're ready for the next one. That's the only way I find comfort, is to say that we're prepared for the next one. And that sort of daily debriefing of what was good, what wasn't, how can we do it better, fits our personality. That's why we're here, and allows us to recalibrate and yet be ready for that emergency and as calmly as possible, be able to direct traffic, ABCs and on.
The debriefing is really powerful. And also when we debrief, just like you said, what didn't go so well, what went well. And when even having debriefings when everything goes well, to be like, everything went really well. Why did everything go really well? We tend to debrief only during when something happens that we didn't want to have happen, but we can always improve even when things go well. I think our time is pretty much done. I have one last question. It seems like maybe are the learners over here, the side. You what? I mean, that makes sense. So, a lot of these things, what I hear is that, yeah, these are great, but I'm just so focused on all these other things, what I need to learn, what I need to know, that I can't think about these things. And I'm curious if that feels similar for you guys. And if it does and you don't want to say anything, just know that you're not alone. If it does, it can also take time. Thank you, everyone, for inviting me.
Thank you very much.